Hello everybody and welcome again to the Expert Eye Radiology channel. This is Dr. Tamer Gaweesh. I hope you enjoyed the last videos, and in this video we will continue with the case review sessions for the knee MRI. So we'll have several cases in this video with increasing difficulty, and we will demonstrate how to examine the case and how to write a well-structured report. But first of all, let's address the quiz case we showed at the last video. And this case, we were asking about this structure. So we reviewed the MRI of the knee quickly, and we were asking about this structure. So this structure is actually a normal structure. This is the meniscofemoral ligament, and it arises from the posterior horn of the lateral meniscus. As you can see here, this is the posterior horn of the lateral meniscus. The ligament arises from the posterior horn, and it courses just anterior to the PCL to insert at the medial femoral condyle adjacent to the PCL attachment. And this is the anterior meniscofemoral ligament. It's called the ligament of Humphrey. We have anterior and posterior meniscofemoral ligaments. Most of the cases, you have either the anterior or the posterior, and in about 15% of cases only you have both of them identified at the MRI and in the anatomical specimen. But the pitfall in this case is we have had a history of previous operation, and so many of you presume this is a meniscal fragment. Of course, this is one of the pitfalls. The history can be misleading, but you have to examine the structure well. And if you do this in a meticulous way, you will see it is just a hypertrophied meniscofemoral ligament. So this is not a pathological entity. This is just a hypertrophied anterior meniscofemoral ligament or ligament of Humphrey. So I would like to acknowledge Dr. Sarah Abdel Salam, because she is the one who got it right, and congratulations, Sarah, and keep up the good work. Now let's start reviewing several other cases. We will begin with this case. This is a 23-year-old male with history of recent trauma, and we will begin as usual with the axial scans. As you can see, the retropatellar cartilage looks good. The ACL attachment is intact. We have a cystic structure right here adjacent to the lateral aspect of the knee, and we want to know what this structure comes from. This is the axial proton density, and you can clearly see this is a well-defined lobulated complex cystic lesion or structure at the lateral aspect of the knee. We are verifying again the retropatellar cartilage is good, the ACL attachment, other muscles and tendons, and there is no significant joint effusion. So now let's go to the sagittal scan and take a quick look. This is of course the medial meniscus. The anterior horn is smaller than the posterior horn. This is normal. And we are going to the central aspect of the joint. This is the PCL. The ACL is rather ill-defined. We will see if it has mucoid degeneration or not in the T1. And now we go to the lateral meniscus, and you can see there is an interruption at the body. There is a linear vertical signal interrupting the meniscal body from superior to inferior surface, and this happens when the body is rectangular in shape. You should see the body like this, but at the central aspect there's an interrupting signal, so this is a vertical radial tear. And if we put the sagittal with the coronal side by side, you will clearly see that this is a parameniscal cyst. So the tear is at the meniscal body, and this tear continues with a small interruption at the meniscal base, and this is actually a parameniscal cyst. And you can see when you go posterior, the lateral collateral ligament is intact, and the posterolateral corner structures are intact, and this is just a radial tear at the body of the lateral meniscus with a parameniscal cyst. So this is a straightforward case. There is no significant pathology. I just wanted to show you how the radial tear would appear. It's always a vertical signal in a rectangle, and when you see it, you just report a small radial tear at the meniscal body. And in this case, of course, we have the parameniscal cyst. I will not be showing you the report for this case. It's a straightforward case. So the first 3 cases, I'll just show you the findings. I have special points that I want to stress on, and I want to make sure everybody can diagnose. Number 1 is the radial tear. Case number 2, we'll start with the axial as we always do. In this case, you can see the ACL attachment looks good. The other structures at the axial scans are intact. There is some sort of pathology at the retropatellar cartilage. Let's just switch to the PD fat, and you can see there is an area of chondromalacia. Right here, the articular cartilage is thinned out. There is an area of chondropathy, and it appears to involve most of the thickness of the retropatellar cartilage at the lateral facet with subchondral cystic changes. So this is a chondromalacia patelli. You can call this patellar chondromalacia grade 3, or you can just identify and describe the chondropathy, but you just have to highlight it because this may be a source of chronic pain for the patient. Now let's switch to the sagittal scans. We start with the medial meniscus. It looks good. And then we continue to the lateral meniscus, and you can see that the lateral meniscus looks abnormal. You don't see the horns. You just see a rectangular appearance from the periphery, from the body, and this rectangular appearance continues to the central aspect of the joint. And when you get the coronal scan, you will see that the medial meniscus shows normal appearance. This is the posterior horn, the body, and the anterior horn, while the lateral meniscus is almost rectangular all through. And this is a discoid lateral meniscus, and this is the second thing I want to make sure everybody won't miss having a discoid meniscus. Most of the discoid meniscus occur on the lateral side, but you can also see, oftentimes you can see a discoid medial meniscus. So take care when you see in more than 3 consecutive cuts at the sagittal, the rectangular appearance is persistent. You can just suspect a discoid lateral meniscus, and you can verify this very easily at the coronal scan. So this patient had the area of the patellar chondromalacia and the discoid lateral meniscus. Now let's begin addressing more complex cases. So case number 3, this is a middle-aged man with history of chronic knee pain. You can see, of course, in the axial scans, the ACL attachment looks intact. The retropatellar cartilage is good. There is a mild joint effusion, mild synovial thickening. Nothing else significant appearing on the T2. Let's switch to the PD fat. The retropatellar cartilage looks very good. The effusion and synovitis are there. ACL attachment is intact, and the PCL attachment, as you can see here, is also intact. We have a tiny Baker cyst. This is the tiny Baker cyst, and slight hyperintensity around the medial collateral ligament. This may be a small sprain. We will verify this, of course, later. So this is the axial scan, doesn't show significant abnormalities. And now let's go to the sagittal scans. So in the sagittal scans, you can see at the lateral side, the meniscus looks good. The ACL is intact. PCL is intact. But you can see here there is a definite pathology at the medial meniscus. So the anterior horn is fine. The posterior horn shows signal abnormalities, and you can see at the root of the posterior horn of the medial meniscus, this is a missing part. This is the ghost sign. And now let's get the coronal beside, and let's start describing the posterior horn medial meniscal pathology. So first, the meniscal root of the lateral meniscus is intact. It crosses the condyle, while on the medial side the meniscal root is very ill-defined. It gives you the ghost sign, and this is a meniscal root tear. Of course, we also that there is mild degenerative signal at the posterior horn. So the posterior horn is hyperintense. There is an intrasubstance globular hyperintense signal, but you have to notice there is a small interruption at the inferior surface at the peripheral aspect of the meniscus. This is actually a tiny peripheral vertical tear that reaches the inferior aspect. I hope you can see this clearly now. So there is a small tear at the peripheral aspect of the meniscus, and you can see it clearly at the sagittal scans. If we zoom up on the coronal, you can also see there is an interruption at the inferior surface and peripheral aspect of the meniscus. So in this case, we have degenerative changes of the posterior horn medial meniscus with a small root tear and a tiny peripheral tear reaching the inferior surface at the red zone of the meniscus. So this is as far as the medial meniscus is concerned, but we have to, of course, know the other pathological changes. First, this is the grade 1 sprain of the MCL. You can notice thin fluid signal, superficial and deep to the MCL, but the fibers of the medial collateral ligament are intact. There is no interruption. So this is just a sprained MCL. And you can note here there is mild marrow edema at the medial femoral condyle. So you can see from the lateral side, the lateral femoral condyle looks good. The marrow signal is homogeneous and the articular cartilage is intact. If you go to the medial side, you can see this marrow edema, and look closely here. You can see this area at the medial femoral condyle articular cartilage. You can now see there is a chondral ulcer. So this is a chondral ulcer at the medial femoral condyle articular cartilage, and you can now see clearly this ulcer doesn't go all the way through. It's more than 50% of the chondral substance, but it does not reach the subchondral bone. There is still a small amount of articular cartilage covering the bone, but most of the or more than 50% of the cartilage width is denuded, and this is a chondral ulcer. And I want to make it clear, when you see a chondral ulcer, you don't just write a chondral ulcer, you have to describe it. You have to measure its width, you have to measure its length, and you have to measure the depth. It's okay to describe if there is just less than 50% or more than 50% of the cartilage thickness involved, but you have to comment on the subchondral bone status. In this case, we would say there is a chondral ulcer at the medial femoral condyle weight-bearing articular surface. It measures, and you can measure it easily, it measures about 7 millimeter in width and 14 millimeter in length, and involves more than 50% of the articular cartilage girth with intact subchondral bone showing minimal reactive edema. So this is how you describe a chondral ulcer. You don't just state there is a chondral ulcer, you have to measure it and you have to comment on the status of the subchondral bone. Of course, this is correlated with the management, because the management decision would rely on the size of the ulcer, on the depth of the ulcer, and the status of the subchondral bone. So such a case, they may have a conservative treatment decision. In other cases, wide ulcers, they may go to mosaicoplasty, they may go to chondrocyte transplantation or allografting, whatever the technique available for the orthopedists. But you have to give them the information they want, because the decision relies on what we tell them in the report. Okay, so this is the medial meniscal pathology. As we said, meniscal degeneration, small tear and root tear, and the chondral ulcer beside the sprained MCL. And we saw in the axials there is an effusion and mild synovitis, as you can verify, of course, in the sagittal scans. So this is the third case. I'm going more quickly in the cases now, but from the next case we will be seeing more complex pathology. So please stay focused, and let's go to the fourth case. So case number 4, this is a middle-aged man, and we will go sequence by sequence and then see what we can find and what to describe. So first of all, the retropatellar cartilage looks good. Now look at the site of the ACL attachment. Of course, all the previous cases we saw the ACL was intact, the hypointense signal was preserved, and of course you can compare this to this case. You can see a fluid signal at the site of the ACL attachment, of the expected ACL attachment, and you don't see any fibers. Okay, so to verify this, just take a look at the axial proton. You don't see any ACL fibers. You see some sort of a bizarre shaped signal at the site of the expected ACL course and fluid signal at the femoral attachments. So before even seeing the sagittal or the coronal, you know this is a full thickness ACL tear. Of course, it's very clear. So the retropatellar cartilage is verified to be intact. We have a good amount of joint effusion, and just take a note about there are abnormal signal structures seen here beneath the MCL, and take another look at fluid components. There are marrow edema changes at the distal femur and the proximal tibia. There are some cystic changes and fluid surrounding the popliteus myotendinous junction. We can call this a popliteus bursitis. So now let's go to the sagittal and coronal to see what's wrong with the menisci. We know now there is a full thickness ACL tear, and we have marrow changes, we have moderate amount of effusion, and we have an abnormal structure lying here beneath the MCL. So now let's jump to the sagittal and coronal to see what's wrong. This guy also gave a history of a previous operation several years ago for medial meniscal tear. He had a previous operation. This is a 40 years old male with a previous history of a meniscectomy, but now you can see there is definite pathological changes at the medial side. So let's take it step by step. On the outer aspect of the knee, you don't see clearly the posterior horn of the medial meniscus, and the anterior horn looks bizarre and shaped with missing part. If we zoom a little, you will clearly see that there is a missing part from the superior aspect of the anterior horn of the medial meniscus. It looks bizarre in shape. The meniscal body is very small and ill-defined, and the posterior horn is ill-defined as well. So compare this to the coronal. You can now see at the anterior horn there is a missing part right here, and there is another meniscal fragment lying just above the anterior horn of the medial meniscus. This is what you call the double meniscal sign, the double meniscus sign. This is how you see a horizontal flap tear. As we said, a horizontal flap tear, you will see part of the meniscal girth amputated, and this amputated part will be displaced either to the center of the joint or to the outer aspect of the joint. So now we can see at the anterior horn of the medial meniscus there is a horizontal flap tear with the centrally displaced meniscal fragment, and you can see the site of the amputation and the displaced meniscal fragment lying just above the residual aspect of the anterior horn. So this is called the double meniscus sign, and when you see this, this is pathognomonic for a horizontal flap tear. Not only the horizontal flap tear is identified, we can see that the body is almost totally amputated. There is no meniscal body. This is just a very small residual part of the body, and there is a loose meniscal fragment seen impacted between the residual meniscal body and the meniscocapsular attachment beneath the MCL. So this is another part of the horizontal flap tear. So we have a horizontal flap, a sizable horizontal flap tear involving the body and the anterior horn of the medial meniscus with loose meniscal fragments seen beneath the MCL and at the central aspect of the joint. So this is a complex horizontal flap tear. This is the type of tear that is difficult to diagnose, that is difficult to describe, but you have to go step by step. First, you note that there is an abnormal girth of the meniscus. When you see abnormal girth of the meniscus, you have to suspect flap tears. There are missing parts. There is clearly a missing part from the anterior horn. Most of the meniscal body is amputated. Of course, this posterior horn is also small and irregular in shape, but this is correlated with the previous operation. And we can see now how the meniscal horizontal flap tear may appear. So now we know there is a full thickness ACL tear, and you can, of course, clearly identify the ill-defined fibers of the ACL along its course. You don't see any intact fibers. If you just take a look at this area, you will note that the tibia is slightly anteriorly translated compared to the distal femur. So there is mild anterior tibial translation, and this correlates with the anterior drawer test the orthopedists do. You just flex the knee and pull the tibia anteriorly, and it comes anterior with you, and you can, of course, imagine how this happens. The ACL fibers are just completely torn and macerated, and the tibia is unstable. And we know that there is complex horizontal tear at the anterior horn and body of the medial meniscus. Now let's see what else is wrong. The lateral meniscus looks very nice. It's intact in the coronal and in the sagittal, but you can see there is articular cartilage pathological changes. One of these changes appears here. This is the anterior aspect of the lateral femoral condyle, and you can see this is the residual part of the articular cartilage, and there is a definite chondral area of chondropathy or chondral ulcer, and we will see this again in the axial scans. So this is the articular cartilage intact, and in this area there is an articular cartilage defect, okay, with subchondral edema and cystic changes, and you can even measure this area. This is an osteochondral defect at the anterior margin of the lateral femoral condyle, and at the medial side you can also see there is diffuse attenuation of the articular cartilage at the medial femoral condyle and medial tibial plateau. And if you correlate this with the history of previous operation, this would be secondary osteoarthritic changes that happen due to the abnormal weight bearing on the medial compartment of the knee, the excised part of the meniscus, and the other part now, of course, has a complex tear, and this apparently is a long-standing process. So what happens next is you get secondary osteoarthritis at the medial compartment. You can see that the medial compartment is narrowed. Compare this from the cortical line here at the lateral compartment of the femur and the tibia, and there is marked narrowing on the medial joint space, and there is diffuse chondropathy and irregularity of the articular cartilage. So to sum this up, as you now see on your screen, how do you report this? We, of course, begin with highlighting there is a post-operative status. And as we said, the body and the posterior and the anterior horn of the medial meniscus show horizontal flap complex tear, as we described. And there is a full thickness chronic tear of the ACL. There is a moderate joint effusion, mild popliteus bursitis, and we have the osteoarthritic changes at the medial femorotibial compartment, and as we described, the small osteochondral defect at the anterior margin of the lateral tibial plateau. So this is the type of cases you get that are cumbersome in reporting. It takes a lot of time, especially if you don't have the reporting scheme and structure clear and ready in your mind. So my advice, when you see this type of complex case, you should take the report, the normal report template, open it beside you, have it printed, or just memorize it, and you go step by step. You go step by step in the reviewing of the case, and when you begin to write the report, just take an item by item and make sure it's intact or pathological. Take another look if you need, just to describe it right, and you go step by step, item by item, to make sure you are not missing anything. So this is a typical case of an ACL tear, and I now showed you how to report a horizontal flap tear. Let's take a moment, and the last three cases we will discuss are more complex and will have different diverse pathological changes. So I will go more slowly in the next three cases to make sure you are following, and to make sure all the pathological changes are clarified and easy to be reported. So this is case number 5. This is a young man with history of recent trauma, and we will go step by step. As we said, we will begin, of course, reviewing the axial T2. Let me put the axial proton density side by side, so when we review we have both of them. So first, the patella and the retropatellar cartilage, they are looking good. Now we will move to the ACL. You see clearly there is very evident abnormality at the signal of the femoral attachment of the ACL, and just like the previous case, this is a clear, straightforward, complete ACL rupture. Note here there is marrow edema at the lateral femoral condyle, and when you go downward there is also marrow edema at the posterolateral corner of the tibial plateau, and there is marrow edema at the fibular head. There is, of course, a mild amount of joint effusion and a small Baker cyst. And let's just review the medial collateral ligament. It looks intact and good. And on the other side, this is the lateral collateral ligament. Also looks good and intact. All the muscles and tendons are good. This is the popliteus muscle, as we said, the popliteus tendon, coursing just behind the lateral femoral condyle. Everything looks good. The patella shows mild lateral subluxation, but this is not our issue here. Medial patellar retinaculum looks good. The lateral patellar retinaculum looks good. So on the axial scans, what we can see is the ACL rupture. We know the MCL is good, the LCL is good, and we see that there are marrow changes at the lateral side of the knee. So we will switch to the sagittal and coronal, and let's see what we can identify. So first, we will go, as we always do, from the medial side to the lateral side and identify pathological changes. We identify one by one. So at the medial side of the knee, we have abnormal signal at the posterior horn of the medial meniscus. This is, I think, is obvious enough. Let's just zoom a little to make sure it is clearly apparent. So this is a young man. This meniscal signal, we will describe this as a meniscal contusion because he is young enough and there are no signs of degenerative joint changes. So we have a meniscal contusion, at the posterior horn. And you can see there is a small interruption, there is a small peripheral vertical tear reaching the inferior surface of the meniscus. And what I need you to see clearly, the abnormal signal and the edema at this area. This is the expected area of the menisco-capsular attachment we saw at the normal studies in the previous videos, and this is what a meniscofemoral meniscocapsular tear would look like. So you see the meniscus is contused, there is a small peripheral vertical tear at the meniscal base reaching the inferior surface, and there is complete ill definition of the meniscocapsular attachment. And this is, guys, this is what you call a meniscal ramp lesion, and we explained this in the previous videos. So by the arthroscope, if the orthopedist goes this way and doesn't reach the apex of this ramp, he won't see this meniscocapsular injury, and it will be missed, the meniscus will be unstable, and the patient will continue to complain after managing the ACL tear. This is, of course, the ACL tear. It's crystal clear, and you can see in this case there is also a very nice apparent anterior meniscofemoral ligament at the quiz case from the last video. So this is a normal meniscofemoral ligament, the ligament of Humphrey, arising from the posterior horn lateral and inserting at the medial femoral condyle. The ACL, of course, is completely ruptured, and we now saw there is the pathological changes at the posterior horn of the medial meniscus. Let's just verify this to make sure there are no other meniscal tears. So the anterior horn is good, the meniscal body is preserved, there are no amputated areas. The medial collateral ligament looks very nice. Now let's switch to the lateral side. This is, of course, the lateral meniscus, the anterior horn and the posterior horn. They both look good, and the meniscal body also looks intact. And to verify this, we will jump to the coronal. This is the posterior horn, the popliteus tendon passing from inferior to superior at the popliteus hiatus. Okay, and this is the meniscal body and the meniscal anterior horn. So we saw the ACL rupture, we saw the medial meniscal pathology. MCL looks good. On the lateral side, this is the lateral collateral ligament, also looks good, and the posterolateral corner ligaments, this is the arcuate ligament, it is intact, of course, and this is how you see it. This is the popliteofibular ligament, this is the popliteus tendon, and the fibular head and small ligament connecting both of them is the popliteofibular ligament, and small ligament connecting the fibular head to the posterolateral corner of the tibial plateau is the arcuate ligament. So these are the posterolateral corner structures. They are both intact, and you can see here, of course, the marrow contusion at the lateral femoral condyle and the opposing one at the posterolateral corner of the tibial plateau, as well as the fibular head. So this is very typical, guys. This is very, very typical pathology you see with ACL rupture, and this is the secondary signs of ACL rupture. So what I want to tell you, if you see in a case of trauma opposing marrow contusions or kissing marrow contusions at the lateral side, always double check the ACL, because this is almost always exclusive for ACL ruptures. You will see this marrow contusion at the lateral femoral condyle and the opposing aspect of the posterolateral corner of the tibial plateau. When you see this, this is one of the most important secondary signs of ACL. What you need to do now, because there are marrow contusions, you have to make sure if there are fractures or not. So let's just take the T1 and make sure if there are fracture lines or not. You can see here at the lateral femoral condyle, the marrow contusion appears hypointense on the T1, and you can see there are trabecular compression changes. So the bone trabeculae at the subchondral area are compressed, they are indented inwards, and this you can call a trabecular compression fracture or trabecular compression changes. And there are similar changes here at the posterolateral corner of the tibial plateau. And if we look closely at the fibular head, there might be a tiny fissure fracture at the fibular head, and we did a CT for this case, and we verified the fibular head. It was a very tiny fissure fracture at the fibular head. It is apparent on the MRI, at least you can highly suspect it, and if you can do a CT or just order it to make sure the diagnosis is complete and any possible fractures are identified. Okay, so this is a typical case of ACL injury, and we saw this in association with a meniscal ramp lesion and the typical posterolateral marrow edema and trabecular compression changes that appear with the ACL. So don't forget this. When you see an ACL injury, you have to look at the meniscal ramp lesions, make sure if there are any of them obvious, and you see the marrow contusions at the posterolateral corner, make sure that the posterolateral corner structures are intact. From the bone, the trabecular compression fractures, the arcuate ligament, the popliteofibular ligament, and the lateral collateral ligament. Each of these structures, you have to be very meticulous in identification of their pathology. Now let's go to case number 6. And this is a case full of findings. Actually, this is as hard as it gets when you are reporting trauma. So in this case, you start, of course, with the axial scans. I'm putting the T2 and the PD fat side by side, and let's take it step by step. First, the retropatellar cartilage and the patella are good. There are no cartilage pathologies at the retropatellar cartilage. The ACL attachment is intact. You don't see any ACL injuries here. But what you see is there is diffuse edema and swelling surrounding the knee joint, and this is more obvious at the medial side. You can clearly see that there are medial side pathological changes. We are used to identify the MCL fibers, and this is the tibial attachment of the medial collateral ligament. Okay, if you go upwards, you will see there is obvious interruption near the femoral attachment of the MCL. So let's just concentrate on the medial aspect of the knee. We don't see the femoral attachment of the MCL. We don't see the attachment of the meniscofemoral ligament and the posterior aspect of the medial patellar retinaculum. They are ill-defined, both of them. And there are, of course, marrow pathological changes, which are more noted at the lateral side of the knee. So we need, of course, to take a look at the sagittal and the coronal scans, and then return back to the axial to see what's wrong. So first, let's start with the posterior horn of the medial meniscus. You can see this is the meniscal body, and the anterior horn looks good. The posterior horn, most of it looks intact, but you can see there is a separated part at this area arising from the meniscal base and directed superiorly, and we have to examine this to see what exactly is the pathology. So this is the posterior horn of the medial meniscus. The root is just reaching the medial condyle edge. You can call this a tiny meniscal root, but there is definitely a pathological area at this site. and you don't see the meniscocapsular attachments of the body very well, especially the superior one. So there is an abnormal signal at the meniscal body. This is the inferior meniscocapsular ligament. The superior one is ill-defined, we don't see it, and this is an oblique horizontal tear at the base of the posterior medial meniscus. This is associated with torn meniscocapsular attachment and this small displaced meniscal fragment, of course. So this is a very difficult meniscal tear to identify. You have to take it very slowly. First we identified there is a pathology at this area. This base of the triangle, there is an amputated part of it. We switched to the coronal. We identified there is superior meniscocapsular ligament injury, and this meniscal tear associated with the meniscocapsular injury resulted in this small loose meniscal fragment. So that's the medial meniscus. We can see, of course, the PCL looks good and the ACL also looks good. Now switching to the lateral side, there is a tiny tear at the anterior horn of the lateral meniscus, and this is reaching the meniscal superior surface, and this is just a small tear. If you see the coronal, you can suspect there is partial, of course, discoid configuration of the lateral meniscus as well, because you don't see posterior horn, anterior horn, and body. You just see it more or less. The body is very big and the rectangular shape is rather preserved. This is a partial discoid configuration of the lateral meniscus, and now we can see clearly in the coronal scans the medial collateral ligament is completely ruptured. So this is a complete MCL rupture involving the femoral attachment, and this is sequel to valgus injury of the knee. So the knee is bent with an angle this direction. You can imagine this is how the trauma happened. The knee was bent this way, and this resulted in tearing of the medial collateral ligament and the marrow contusions on the other side. So we have now to identify these marrow changes. The fibular head looks intact. You have the marrow contusion at the lateral femoral condyle. There is an obvious subchondral trabecular compression fracture, just as we saw in the last case. The subchondral bone shows a sclerotic compressed line at the lateral femoral condyle, and there are similar smaller marrow edema changes seen at the anterior aspect of the lateral tibial plateau. And we have, of course, when you see these type of marrow contusions and marrow pathology, you have to always check the T1, and when you check the T1 you will see there is a fissure fracture at the anterior aspect of the lateral femoral condyle, and the compression trabecular fracture at the lateral femoral condyle is very obvious. So we have at the lateral tibial plateau, we have this tiny fissure fracture and the marrow contusion and trabecular compression at the lateral femoral condyle. The fibular head is intact and the other structures are intact. What we missed in this knee as we are going through, there are two incidental lesions. So there is this structure right here, which is a small osteochondroma arising from the lateral femoral metaphyseal area. This is a very clear small osteochondroma. And unfortunately, the axial scans were starting just beneath its level. So this is the osteochondroma base, but it's very obvious in the sagittal scans with a clear, well-defined, homogeneous cartilage cap. So this is an incidental lesion. This is an osteochondroma, And as we saw in the T1, of course, there is just a heterogeneous area of subchondral sclerotic marrow lesion, and this is mostly a healed non-ossifying fibroma. So this is an incidental finding. There is a healed non-ossifying fibroma at the distal femur, and there is an osteochondroma as well. So this is a case full of pathology. Now I'm putting the report on your screen, and you can see this is just the conclusion. I'm not putting the report because this is just a lot of findings. The report actually was 2 full pages, and this is the conclusion. So we had a full thickness tear of the proximal attachment of the medial collateral ligament with complete tear of the deep MCL fibers, and this is sequel to valgus injury. As we explained, there is a moderate soft tissue edema and hematoma underlying partial tear of the posterior oblique ligament. Yes, I forgot to elaborate on this. So as we said before, this is the posterior oblique ligament. This is starting just above the level of the MCL attachment, and this is torn as well. So you have also a partial tear of the posterior oblique ligament. There is a sprain of the medial patellar retinaculum, oblique horizontal tear at the base of the posterior medial meniscus with torn meniscocapsular attachment as we described, and the meniscal fragment, the tiny tear at the anterior horn of the lateral meniscus, the sizable marrow contusions as we elaborated with the tiny fractures, and as we said, there is a small osteochondroma and soft tissue edema and the joint effusion. So this is one of the most difficult cases you can see, but if you go step by step, you have to think logic, you have to take it slowly and identify each of these pathologies on its own. So now I'll switch to the final case, and this is case number 7. I will try to go this quickly, just elaborating on the findings. First of all, you can see at the retropatellar cartilage there is an area of chondropathy, near full thickness denudation and chondropathy involving the retropatellar cartilage at the medial facet, and you can see there is minimal subchondral marrow changes. You can of course clearly now identify there is a complete or high-grade ACL tear. And one small thing about the ACL tears, as we said in the previous PowerPoint presentation, you call it a high-grade tear when there are more than 50% of the substance involved, and low-grade tear when there are less than 50% of the substance involved. So a high-grade tear with like 70 or 80% is the same consequence of a full thickness tear. So if you are not sure this is full thickness tear or just a near full thickness tear, it's the same. Management wise, it's the same. You can call this a high grade tear, you can call this full thickness tear, it's the same. The management will be always operative. What you have to identify is the low grade tear or the tiny partial tears, because these are managed conservatively. But once you have more than 50% of the ACL injured, most of the time, especially when the patient is young or active, they will need ACL grafting. So in this case, we have the ACL tear, we have the chondropathy, and you can now, of course, clearly see, let's switch back to the T2, there is also pathological changes identified at the medial aspect. This is more or less similar to the previous case. You can see the distal fibers of the MCL, and you can go up with this up to the femoral attachment. So the femoral attachment actually looks good. So there is an injury at the medial side, but it's not primarily involving the MCL, and we have to check this again. Let's take a look at the medial side, at the lateral side, I'm sorry. So these are the fibers of the lateral collateral ligament, and you can see them coursing from the lateral femoral condyle down to the fibular head, and you can also see there is mild fluid signal surrounding these. So switching to the coronal, you can see that the MCL fibers, they are intact. Okay, so they are just sprained, and the lateral collateral ligament is also sprained. So we have a sprain of the medial and lateral collateral ligament. So what is this injured structure? This is the medial patellofemoral ligament, and this is a complete rupture of the femoral attachment of the MPFL, the medial patellofemoral ligament. So this is for the pathology at the medial side. You can of course see there is moderate amount of effusion, there is soft tissue edema, superficial in the subcutaneous tissues and surrounding the knee joint. And getting the sagittal, as we said, we have to take it step by step to make sure we are not missing anything. So, examining the medial meniscus, you see the anterior horn looks good, the meniscal body is good, and the posterior horn, you don't see a signal in the posterior horn. But as we said before, this is totally abnormal. This is the site of the meniscocapsular attachment, and this is totally abnormal. So we have ACL injury, we have meniscocapsular injury at the posterior horn of the medial meniscus, and this is, as we said, a meniscal ramp lesion. So the posterior horn looks good, the substance is good, and the body and the anterior horn are nice. You have ill definition of the superior meniscocapsular ligament as in the previous case, and there is a meniscal ramp lesion. The meniscocapsular attachment related to the posterior horn is completely ill-defined. So this is regarding the medial meniscus. Switching to the lateral meniscus, there is a good normal appearance of the anterior horn, meniscal body, and the posterior horn. We see there is a linear vertical signal at the meniscal base. So this is the coronal scan. Let me just zoom up a little, and I hope you can see this clearly now. There is a vertical linear longitudinal tear at the meniscal base, and this is also a meniscal ramp lesion. So in this case we have an ACL tear, we have meniscal ramp lesion at the medial side, and another meniscal ramp lesion at the lateral side. So we have meniscal ramp lesions of the medial and lateral sides. We have sprains of the medial and lateral collateral ligament. So as we stressed before, when you see an ACL injury, just take a look at the lateral aspect of the knee, because this is the most common site of marrow injuries and compression fractures. So we see here there is a tiny marrow contusion at the lateral femoral condyle. This is very common. This is the most common scenario, and you will see associated another sizable marrow contusion at the posterolateral corner of the tibial plateau, and the marrow edema and contusion at the fibular head. And this looks like a fracture, and we will have to just get the T1 to help us to see if this is actual a fracture or not. You can now see there is a fissure fracture at the fibular head, the tiny compression fracture at the posterolateral corner of the tibial plateau, and the marrow edema and tiny trabecular compression changes at the lateral femoral condyle. So in this case we have the full-blown picture of the ACL injury. What you have is a high-grade ACL tear, meniscal ramp lesions, medial knee injury. We have sprained MCL and complete tear of the medial patellofemoral ligament, and you have the typical marrow edema and contusions, which are always apparent with the ACL injury. And of course you don't forget this area of chondropathy. So again, a very condensed report. I'm just showing the impression because the report took 2 full pages to describe, and just take it step by step. I'm trying to put cases with multiple pathologies to speed up our reviews. So take it step by step, examine each structure on its own, and make sure you are not missing the difficult and hidden lesions, the horizontal flap tears, the meniscal ramp lesions, and I'm trying to show you all the appearances they can have, either the isolated meniscocapsular ligament as you see here, or peripheral longitudinal tears, or combination of both. So we will stop here in this video. This is just a last case I want to show you. This is also a case with an ACL injury and medial collateral ligament injury. What I want to show you in this case is just the posterolateral corner injury. We have in this case the small contusion at the lateral femoral condyle, the posterolateral corner of the tibial plateau, but I want you to see this area. There is complete ill definition in this case at the posterolateral corner structures. So we have, as we said before, the arcuate ligament and the popliteofibular ligament. Both are ill-defined. You cannot identify either of them. So this is more or less similar to the previous case, but the posterolateral corner injury is more severe. So this is the last thing in this video I want you to see. This is the appearance of a posterolateral corner injury, and this is torn arcuate and popliteofibular ligaments. So guys, thank you all. I know we are all having a headache right now because of these exhausting cases, but remember, always take it step by step, and if you see a complex case, don't panic, just review item by item, and when you write the report, make sure you are not missing the comment on any of the structures of the report. And good luck to you all. See you in the next video. The next video will be the last video addressing the knee. We will take a quick review on the post-operative changes, how to describe them, and addressing cases with ACL grafts and their complications. And this will be the last video next time, addressing the knee. After that, we will begin with the MRI of the shoulder, and then maybe we will jump to another specialty. Thank you all again, and don't forget to subscribe and hit the notification button to get all our updates, and see you on the next video. Bye bye.